Hello, my name is Charles Goldfarb, and I'm joined by my co-host Alexander Aleem for the AOA podcast, Lessons in Orthopedic Leadership. We continue to host a variety of guests and will continue to tackle topics of interest to all leaders, but especially those in orthopedic surgery. Each episode will welcome a guest with an expertise in a crucial leadership or clinical care area. This week, we do indeed have two very special guests in an episode addressing bone health and how orthopedic surgeons can play a sometimes unfamiliar but increasingly important leadership role in the bone health care of orthopedic patients. One of our guests today is Kelly Krohn, a rheumatologist with the Core Institute. Dr. Krohn has tremendous knowledge in the area of bone health, and he is here to share some things he would like orthopedic surgeons to consider concerning the importance of a bone health specialist to orthopedic surgery practice.
Yeah, thanks a lot for the invitation. It's a topic that I'm excited about, and I have plenty of experience from universities, drug companies, and now a large academic clinical practice.
Fantastic. So, we are hosting this podcast in recognition of the AOA's Own the Bone program, which thinks about orthopedic surgeons and their relationship to bone health. How do you think about that? What level of comfort should we as orthopedic surgeons have with the advanced medications and the treatment, streamlines for bone health? Or is it more important that we have a strong relationship with a bone health provider like yourself?
There are different scenarios in every city, every group, every academic department. There are orthopedic groups around the country. I'm thinking of HSS and Joe Lane. Joe Lane knows as much about these drugs as I do, but that's rare. He's an accomplished trauma surgeon. He happens to know metabolic bone really, really well. Okay. Most orthopedic practices and academic programs do not have a surgeon who wants to spend the time to learn how to be a pseudo-endocrinologist, right? And they'd much rather pass it to somebody, but that's the crucial thing, passing it to somebody they trust, passing it to somebody and giving them some advance notice. Here's what I want you to do. So I really think the best scenario is an embedded clinician within a larger medium-sized orthopedic practice. I know practices of 6 orthopods who can support a complete bone health program. Now, many of those are PAs or nurse practititioners. In my 10 years at Lilly, I spent lots of time mentoring lots of PAs and nurse practitioners because they really didn't have anybody to ask the hard questions, right? So to me, it doesn't matter, mid-level, experienced clinician, but behind that person, they should have a network where they can contact somebody by email or call and ask tough questions. And there's lots of ways for people to learn more, and I can go into that if we choose to.
I think that's a great, part of what you're saying is that how do you integrate that person into it? And you've talked about, I think the thing that intimidates maybe some groups is you think you have to have a large group in order to support someone that's dedicated to bone health because you think it's maybe a rare problem. But I think as we are uncovering more and more, we see that there's the obvious fragility fractures and osteoporosis fractures, but there's potentially more ability to treat and maybe prevent some of these bone diseases, especially fragility fractures, if we have a heightened awareness, and having somebody within your group probably helps with that. What are some of the strategies that you've seen that have been successful when you're integrating a new person into a group to try to make sure that they're staying busy, they're being able to deliver? Because it is a little bit of a bottom line in terms of the financial business. So how do you kind of see that when someone's initially coming into the group?
And it's not always easy. I don't generate a lot of income. I'm a break even, getting paid like an internist, which is, I'm not complaining. I'm just saying it's tough to generate a lot of income. And we used to be able to generate income by doing bone density studies and infusing drugs. Well, that's pretty much all gone now. So you're really dealing with your CPT codes, And now if you give a shot in the office, they don't want you to do a office visit, so there's a lot of barriers that are really frustrating to me as somebody who tries to make a living doing what I do, but I'm okay, and fortunately I'm retired VA and retired Eli Lilly. So, but I think one thing that's valuable, what I've noticed, the most successful mid-levels who do bone health for an orthopedic group, medium size, 6 to 10, large, 40, 50, whatever. The most successful ones have a history of doing orthopedic work as a PA or nurse practitioner. And some of them, by the way, are mid-career and they want to get out of call, right? You know, so there are people often within a practice who might want to do this if they knew it was possible for them. And then they got to hustle, because they got to hustle within the group. They got to go around and meet everybody who takes call and takes care of fractures. They got to go meet the spine surgeons and say, hey, I'm interested in preoperative evaluation. You know, you're not going to sit back and twiddle your thumbs. Core hired some nurse practitioner before I got her. She sit back and twiddled her thumb. She was gone in 4 months, you know. And I've survived academic and industry. I'm a little bit of a hustler. So I knew how to do that. Plus I knew half a dozen of my new partners. Okay. And really critically, I'm embedded. And Core has 8, 9 offices, I think, throughout the Phoenix Valley. I'm in 5 of them. Okay. So in other words, I go to different offices, different days, and I walk down the hall and introduce myself to some new guy or whatever, you know, and I think that's pretty important, you know, and then you develop a trust and you develop good communication. Amini's got to let me know why he wants me to see this patient. And then a 2-sentence email, I'm ready, right? And then vice versa. I see somebody back and I see that acromion fracture is looking like it's healing. I'm quick to send him an email, right? So it's not an easy financial deal. I know that, but it can be done. You know, and the great Joe Lane, once I'm sitting in his office in New York City and we're talking about this, and he lifts up his pants leg and he says, Kelly, I got socks. So he's just basically saying we can make a living, but it ain't, you know, I don't drive a Maserati.
I love it. I love it. Talk to me a little bit about, and I recognize that your approach may not be the same approach as Joe Lane and other bone health experts. What's your approach? I'm a hand surgeon. Should I be sending every woman over 65 years of age who sustains a distal radius fracture to a bone health expert for laboratory and DEXA assessment? What's the best flow? Do I do the lab work and then potentially send them, or do I just send them? What's your preference?
To be frank with you, just send them, because a lot of times my partners order some labs that are unnecessary. Okay. And if there's another issue like fracture healing, I'm going to order some other stuff, you know, so DEXA plus minus, you know, you do it or don't do it. I'm going to end up doing it and they got to go get their lab and then get their DEXA at the same time. And Core does not do DEXAs because it loses money. Okay. So I have to send them to radiology sometimes. Okay. So my bias is don't order a bunch of stuff. Okay. And I hint that back to my partners, and don't put everybody on 50,000 units of D2 every third day, because that's 1970s medicine, and let me manage the bone. Okay. Including the workup. Okay. And yes, 50 plus with a distal radius fractures should have a visit with somebody like me. If you look at the epidemiology, it's pretty remarkable how many people who had a wrist fracture early go on to have a hip fracture. So those are people often at risk, not always. And I don't put every 50-person-year-old with a Colles fracture on drug, but I ought to evaluate them.
That is super helpful, and I think I can see Chuck writing that down as a take-home point.
as an over 50-year-old. Yes.
Well, I just got my Medicare card, so I meet
there the next. Go. I love it. You know, kind of similar question. Vitamin D screening has become really hot when it comes to even elective orthopedic surgery. I know a lot of total joint surgeons are looking at this. We have kind of looked at this within shoulder arthroplasty. Part of it is, you know, maybe a surrogate for osteoporosis and maybe a surrogate for overall health. But you kind of just said, you know, don't shotgun treat somebody 50,000 units. What's your take on kind of some of us trying to do some of this pre-screening work? And is it, again, you know, leave it up to the experts who are embedded in the practice to really know?
I'll bless you with using vitamin D. Okay. But I specifically said 50,000 of D2 because that's plant vitamin D and we're not plants. So D3 is what we make and it's what sheep make. So the D3 that you get at CVS comes from they shear the wool and they squeeze out the oil and they get the D3 from the sheep. And the average person does extremely well with about 2,000 units a day. But there are people, maybe they have celiac disease that's hidden, maybe they had iliac bypass surgery. I got people on 40,000 a day of D3, but 98% of my patients are on somewhere between 2 and 5,000. And then you don't check it all the time. It takes 3-4 months for a fat soluble vitamin to come to equilibrium. So you check it at 4, 5, 6 months. And if it's still low, give more. And the goal is easy, 40 to 60. 100 is toxic. And with COVID, there was stuff out there about D and COVID, and it was misinterpreted. If you were profoundly vitamin D deficient, you might have a worse course with your COVID. But that doesn't mean you and I should take excessive D, okay? And we hear that all the time, So I was very blessed. My mentor at Creighton University was the world's expert in vitamin D, and he is quoted virtually at every bone meeting I go to, and he's been dead 8 years. So that tells you he had an impact, right? But, it's not hard. It's a fat-soluble vitamin. You treat with D3. You shoot for a goal of 40 to 60 nanograms per ml. And if it's too much, you'd use less. If it's too low, you give more. And I do believe an orthopedic surgeon can handle that.
Well, here's the follow-up, which may have been part of Alexander's question. If not, it's my question. If there is a lab done, a shotgun lab for example, and it turns up a vitamin D level of 18, otherwise bone healthy, no issues, do you treat that?
Absolutely. Because especially they're in an orthopedic office, I assume, so they may be having some procedure. And there, as you know, there's evidence out there that people with really low Ds might have less good outcomes. So why not get it up to 40, right? Which may also down the road help their fracture risk, but it makes sense. I've been taking vitamin D myself personally for 35 years, not a lot, a couple thousand a day. And if you forget it, it's no big deal. It's a fat soluble vitamin, but yes, you should treat low Ds.
You have a particular expertise in Forteo and a knowledge that I'm sure is perhaps unmatched. Share with a bunch of orthopedic surgeons how you think about the indications and potential contraindications or relative contraindications. What type of patient in 2022 benefits from Forteo, and when should we be thinking about that medication for our patients?
Yeah. So, and we have a second drug called abaloparatide or Tymlos. I would characterize them as Coke and Pepsi. So let's just put them in a bunch, and they are PTH-based pulsatile anabolic drugs. So you give a shot, and you get a rise in the level of either PTH or PTH-RP, which is what abaloparatide is, and that creates a wonderful anabolic biology. And it is a remodeling anabolism. That's crucial, okay? Because if you think about fracture healing, you think about fusion of the spine, that's a remodeling biology by and large, right? So the other anabolic is known as romosozumab or Evenity. That's an anti-sclerostin antibody. Very good for osteoporosis, doesn't work to help heal fractures, okay? Because it just lays new bone on top of old bone. It doesn't remodel. And the biology of fracture healing is intense remodeling, right? So the indication for these drugs, in Forteo, the indications are postmenopausal women at high risk for fracture, men at high risk for fracture, and patients on glucocorticoids at high risk for fracture. By the way, that's why I got recruited to Eli Lilly, because I was a prednisonologist, right? I was a rheumatologist in a university, lots and lots of prednisone, okay? And I was mentored by the people at Mayo Clinic who gave the first patients in the world steroids. So I had insights into, they knew, by the way, 1949, they knew that prednisone caused compression fractures. Think about that. And we still give that crap out too easily, okay? So there are clearly patients at very high risk. Now, my definition of high risk and the insurance company's definition are not always in alignment, okay? And these are very expensive drugs. Co-pays up to $1,000 a month if you're covered. Retail, $4,500 a month or $2,500 a month. Now, I happen to live close to the Mexican border, so some of my patients get Forteo for $500 a month. So there are ways to be creative, but these are very expensive drugs. So I got to be convinced that the risk of fracture is quite high. And then I look the patient in the eye. Would you give yourself a shot in the belly every day? Because if that answer is no, I'm not spending a lot of my time trying to get it paid for. And I try to work with a single pharmacist, and I send the prescription and an email describing the clinical situation, and they do a lot of the prior auth work, okay? And then they call the patient up and say, Mrs. Smith, you got approved? Bad news is your copay is $800 a month. That's a deal killer. So we can't do it unless sometimes I do use some samples. I still have samples of Timlos. I might use it to help a fracture heal, but that's off label, okay? I can talk about off label because this is not a drug company thing, but I believe, and as you pointed out, I got lots of experience that a PTH-based anabolic drug might help fractures heal, might enhance the likelihood of fusion, and for sure reduces the risk of a pedicle screw pulling out or an adjacent segment fracture. That's osteoporosis, right? So the drugs are great. They reduce spine fractures by 85%. You can't beat that, So it's just it's the economics and the social work that kill me. It's not the drug. I love the drug. Now, the warning about osteosarcoma, not gone, but almost gone. Big part of my 10-year career was answering lots of questions about the rats who got osteosarcoma. So Lilly was mandated to do a huge human post-marketing study. And about a year ago, FDA lifted the boxed warning for osteosarcoma and Forteo. That's big. You don't hear FDA pulling stuff off. But we had huge studies. There was no hint of human osteosarcoma. Biologically, it makes sense because rats never close their epiphysis, and rats have no reversion remodeling. They're different bones than humans. So that's a big deal. And your patient will come, I read on Dr. Google that I get bone cancer. Well, FDA has actually taken that warning off. That helps a lot.
That does help a lot. But I think, just anecdotally, the biggest thing that I've seen when trying to get that, as you mentioned, is the cost and the access. Yep. And the cost is really a deal breaker. Are there other, drugs or maybe more economical solutions that we have? Because in talking to people kind of in your area, Forteo was a game changer when it came out, because it was really the only, as you mentioned, anabolic kind of bone forming drug that we have for osteoporosis treatment and prevention. Anything else that's out there that might be somewhat not equivalent, but at least giving you kind of similar type benefits that might be a little bit more accessible for our patients?
Yeah, a little hope on the horizon. There's a generic teriparatide now, or a biosimilar. It depends on who you ask. It's like $2,500 a month, which is less than $4,500. It's still quite expensive. These generic companies, they know they can come in pretty high, just not quite as high as the proprietary drug. Okay, and there will be more, I hope, and I hope they fight about price. But for now, we're dealing with a very expensive molecule to get the first 34 amino acids of PTH. Okay, and the other anabolic is romosozumab. Evenity is it. And I tell you, there's a big difference there, because we give shots of Evenity in the office, and that goes for Medicare Part B. I write a prescription for Forteo, and that goes through Medicare Part D. And a lot of people have crappy pharmacy plans. So you got to be a social worker, but you can find really good drugs. And then we have good anti-resorptives. We have bisphosphonates, which I still think are good drugs if you use them properly. And we have denosumab, which blocks the formation of osteoclasts. So we have other good choices that are more affordable. But boy, I'd like to give more Forteo and Timlos, to be frank with you.
So, and not to belabor the point, if I walk into your office, I'm over 50, I have a distal radius fracture, and I've had a DEXA scan, and I have, borderline osteoporosis, what's your first line treatment for me?
Yeah, so I think, first of all, any man who has really low bone density, so borderline osteoporosis, remember, it's like a cholesterol test. It's a spectrum of risk. There's no magicness at minus 2.5, right? So let's say you're minus 2.48. Well, and you broke your wrist with a ground level fall. I'm worried that you might break something else when you fall again, right? So I have no problem with bisphosphonates in that set. Okay. Now, most importantly, even though it's a broken wrist, for sure, if it's a broken vertebra, I'm working you up for multiple myeloma. I'm not going to miss that. Okay. Mm-hmm. I saw Tom Brokaw on TV the other day. He bent over like this. Yeah, he had myeloma. He's got 4 or 5 compression fractures, right? And I tell these older men that. I say, you remember Tom Brokaw? He looks like this now. Oh, yeah, I saw, So you got to rule out something weird in a man, especially with vertebral fractures, okay? And I diagnose myeloma 6-7 times a year. Wow. And I have a good hematologist to send him to, right? I think a younger man with a ground level fall Colles fracture, that's a hint of fragility to me. Whether you call it osteoporosis, I don't care. It's your risk for future fractures. If you've gone over the hump that I think the benefit of the drug outweighs the risk, I'm willing to do that drug.
So what if it's sorry to interrupt, Alexander. What if it's a 70-year-old woman, same situation, minus 2.5, wrist fracture, same answer, bisphosphonates?
Yeah. I don't give 70s kind of borderline for me, but remember, I can only give that bisphosphonate for 4 or 5 years, and then I'm done for life. I do not give oral bisphosphonates more than 5 years, okay? And you might get away with that. Give a man 5 years and see what happens, okay? That woman's going to keep losing bone, though, right? She has osteoporosis. She's going to continue to decline. So my drug of choice for the older woman with a fracture and low bone mineral density is often denosumab or Prolia, because I can give that virtually indefinitely. And the efficacy is better. It reduced fractures by 70%, where bisphosphonates 40, 50%. So, and it's darn simple. Okay. Also expensive, but pretty well covered by Medicare Part B and whatever insurance they have. So there's no absolute algorithm and template, and my core people want me to do that. And there's a lot of variability. Right. We all know that in individual patients.
Maybe switching gears and kind of going towards younger patients. I think last year when we did this, we talked a lot about kind of stress fractures, especially in athletes or young women, as being almost a precursor for osteoporosis later on in life. What is kind of your take on, 18-year-old cross-country runner stress fracture in the, first or fifth metatarsal or a tibia stress fracture? How much of a workup are you doing for that? And then what kind of, long-term things are you looking to monitor for them?
Well, to start with, they're tough, right? And I have several friends who are team doctors for professional athletic teams. And that kind of doesn't count because they're dealing with a different level of athlete with a lot of money on the line, right? So I had a friend, Elliot Schwartz. He was team doctor for the Golden State Warriors and the Oakland A's. And he really was an expert in stress fractures and treated them quite aggressively, but half of his patients were 7'1", So your typical high school, college athlete, I'll do what you do. I treat them conservatively first. I make sure their nutrition is good. And that includes protein, by the way. A lot of these women, especially that have low bone density and fractures, they're semi-anorexic, right? And they have low caloric intake. So the real experts on the terrible triad of women, they're not pushing estrogen or drugs. They're pushing calories to a great extent, right? So I make sure their dietary intake is good. Once in a while, if this stress fracture's into its 5th month and they've closed their epiphysis, I will give them teriparatide or abaloparatide to try to help it heal. But then I'm still stuck with, what do I do long term? A lot of times I don't do much. Sometimes I'll look them in the eye and say, do you really love cross country?
I love that. This has been incredibly insightful, and I know that all our listeners are going to love this. As we wind down, I guess I would ask you, Dr. Krohn, what are your last words as you think about orthopedic surgeons and our relationship with bone health? Clearly, you're a believer in the model of integrating and really leaning on a true expert, but share some thoughts with us as we close.
Yeah, so I think you nailed it at the end, is that I believe the best approach is an integrated approach. I'm in clinic right beside you. We're bitching about the EMR at the same time, right? We have a personal relationship. Hey, I just saw this guy. He had a stress fracture. It's going on 4 months. Would you be able to see it? Sure. Okay. And we do a lot of that at core. Okay. And I think it's really important that the person doing this has some level of expertise. I know some PAs and nurse practitioners that are better at this than lots of endocrinologists, right? because they've gone out of their way. I'm going to give a plug for a kind of a study group that we have. It's called Bone Health Echo, ECHO. It's based out of New Mexico. They run echo programs for lots of specialties, but the bone health one's been going on for 9 years. We do a Zoom call at noon Mountain Time every Tuesday. And I block off time because I learn something every day. Okay. For a nurse practitioner, PA, somebody early in their training, it's fantastic. So somebody does a 10, 15-minute didactic. We had a nutritional talk the other day. I didn't understand some of it, but it was really good. And then we do cases. And a lot of them are presented by nurse practitioners or PAs who are in the middle of nowhere. They got nobody. They got no Kelly Krohn to talk to. And that's a problem. There's not that many of me, but if you have an aggressive nurse practitioner and they went to some meeting and heard somebody, most of us who are in academics like talking to people from out of state who call us about a tough patient, right? And what does that take you? 30 minutes or 30 seconds? I mean, it's nothing, and I did a ton of that at Eli Lilly. If you had a complex problem and you asked the Lilly drug rep, well, they couldn't answer 99% of the questions technically or legally. But you could call me and I could talk to you and I could give you the up-to-date information. And I enjoyed that. That kept my toe in practice while I was a drug company guy. So embedded, well-trained, go out of their way to learn. And there's a handful of good meetings around the country. There's a meeting called the Santa Fe Bone Symposium. Beautiful place to go in August. 3 days of bone. Just really good. Run by clinicians. Okay.
This has been great. I'm getting back into my bone metabolism endocrine days from second year medical school, and it's exciting, and your enthusiasm for this is absolutely infectious. And I learned a ton just in the brief time that we had to speak.
By the way, it's the only thing I know.
You know it well.
But it's so great.
I mean,
this is
learn new stuff.
It's been great. I was taking notes for my own self just to, already come into my clinical practice. So really appreciate the time, and thank you so much for joining us.
Right. And I enjoyed it. And I enjoyed my 10 years of going to AOA meetings and meeting your leadership all the time. It's a wonderful organization. I'll tell you what separates you. I go to AO meetings. There's a lot about leadership and training and how do you manage mentoring. None of that in the medical world, so I think you as a specialty do a much better job developing leaders than any internal medicine organization I've been to. So kudos to you.
Thank you. That is music to our ears.
Our other special guest on the podcast today is Kyle Jeray, who is chair at Prisma Health, Upstate, and has long been an active leader at the AOA, including for its Own the Bone program. Dr. Jeray will share why orthopedic surgeons should take ownership of the bone health of their patients, and how bone health now touches upon all of orthopedics.
It's great to have you, and honored that you take the time to talk to us. Own the Bone is a program that the AOA started several years ago, and really trying to focus on sort of orthopedic surgeons, repeat myself, but owning kind of everything that comes, especially with bone health. It makes sense as a trauma surgeon, sort of to really take ownership of that. But maybe kind of first question, expand it to every orthopedic surgeon. Why should I, as a shoulder surgeon, really kind of buy into the Own the Bone program, or kind of try to figure out about bone health when I've got, cuff repairs and shoulder arthroplasties that I'm worried about?
Yeah, no, it's a good question. I hear a lot of that across orthopedics in general. And probably the thing I hear the most, especially from the traumatologist, is why would I want to prevent a fracture, since it's what I do, is I do fractures to make money, and that's my livelihood. But, we treat more than fractures. We treat patients, and we want to fix the underlying disease. And if we do that, we're still going to have more than enough patients to take care of. But really getting back to your question, I mean, Own the Bone started around 2009. So it's been going a long time. And originally it was looking at preventing fragility fractures, which we think of traumatologists. On the other hand, a lot of general orthopedic surgeons all across the country are involved in taking care of geriatric hip fractures and wrist fractures and proximal humerus fractures. And now we consider low energy ankle fractures a fragility fracture. So that touches on a lot of different specialties. But one of the points I wanted to make with your question that I think is really interesting is that we've looked at it and now start to recognize that as we cross these subspecialties, it's more than just preventing the fragility fractures. we see advantages of taking care of bone health in the spine world. So their instrumentation is better and the screws tend to pull out less, and we can make a patient safer with better bone quality before they have their fusion, for example, or a total joint that's going to get fit in a healthy person, but maybe has osteoporosis. If we can tune up their bone quality a little bit, we may increase bone growth and prevent intraoperative fractures. So it's expanded a lot over the last 15 or so years, and it's not just fragility fractures. And so it touches, I think, on all of orthopedics. Long answer, but I think it's important to hear that.
That was perfect. That was a great explanation. Can you share with our listeners how you established your program at Prisma with Own the Bone and how it helps you manage patients today?
Sure. So as a traumatologist, we have a morning checkout every morning, and we see all the patients that come in. And I have 4 residents a year at our program for 5 years. We recognized early on in 2006, actually, that we're seeing a lot of these fragility fractures, and we weren't doing anything to treat the underlying problem. In 2009, Own the Bone came along, and they published some data in 2008. And it really showed that we can make a difference by treating the underlying problem, decreasing these fragility fractures and hitting these patients that we consider have that sentinel moment when they have that fracture. So we started in our hospital with our residents, very generically, using a lot of the Own the Bone tools and the information on their website, and really got a lot of education from the website, which is, I think, probably the most important part. When we think about Own the Bone, everybody thinks about the registry, and there's about 280 programs involved. And yes, we put patients in a registry, and there are registries for total joints now, and we're seeing them for trauma, and we're seeing them for shoulders, etc. But it's really the education that you get, helping you develop and put together that fragility fracture program in your hospital. And so it started as a grassroots for us with our residents, and we expanded and eventually hired a nurse practitioner who's helped manage and educate and counsel these patients. And using the Own the Bone website, we get pamphlets for patient education off that site. And it's very useful in addition to education that we'll talk about maybe more. But that's really how we kind of got started, sort of grassroots with our residents and using some of the basics with the Own the Bone at their site. And then we moved on from there.
Interesting to see what kind of that looks like now. The residents, as you mentioned, they cycle through it. I think it's an important part. It's probably, honestly, when I look at my resident curriculum, I don't think we do that great of a job sort of educating on the prevention. It's very much treatment. What's your support system look like now? And then kind of how do you really made sure that the resident education component of that carries through? Because obviously beginning a lot of excitement, but it's been 13 years. Is that enthusiasm still there?
Yeah, so you definitely have to have a site champion. You have to have somebody who really feels like they want to continue to push it. And, when I started the program, I was that site champion, but I've really passed that baton on to our nurse practitioner, who now has become that site champion. And so our program has really morphed over 13 years. When we started, it was myself, my trauma partners, and a grassroots effort from our residents using the Own the Bone program. And since we've developed and had a nurse practitioner, then we have a second nurse practitioner, we have a bone health educator. So we've really grown. And what's fascinating to me is, and every community is different, but in our community, there was nobody that was really interested in managing bone health. Our endocrinologists were more concerned with diabetes. Our family practice doctors weren't interested. And so now our nurse practitioner is kind of the guru in our area. And when there's difficult cases and people want to know how to manage osteoporosis, they refer her to patients or they call her, and that's kind of flattering. So our program's really morphed and changed over the years. And one of the things that she's done really well is gotten educated through Own the Bone. And we have webinars and we have echo program that's once a month. And so she takes a difficult case and can present it, and really has grown to be that expert through the assistance of the Own the Bone and the educational materials that we have. So it's been exciting and seeing it grow.
Yeah, it's interesting in St. Louis, we can refer to our endocrinology bone health peers, but it might be a year or so before they're seen. And so, I think that's probably a universal experience. So
Yeah,
tell
it
us, yeah, walk us through, and I recognize there's probably a couple of different pathways, but walk us through a patient scenario where perhaps a patient with a fragility fracture of the hip comes in. How do you think about the when and the how to engage your nurse practitioner or the program in general?
Yeah, so for us with a hip fracture, it's an inpatient, and so we have a captured audience. And what's nice is they're there and their family's there. And if there's dementia with our hip fracture, the family often is who we're looking to counsel. If not, we counsel a lot with the patient. But it literally starts the day they hit the ER. When the resident sees them, they check a box on our standard order set, and that order set automatically triggers a consult to our nurse practitioner, and she will see the family and the patient most of the time prior to surgery, but always after surgery, and talk about bone health program, talk about Own the Bone, address the underlying bone concerns that we have, tell them they're at risk for another fracture in the next 2 to 3 years, probably at 50% or higher. And those types of information really trigger the patients and their families to consider being treated. From there, they get referred to see Laura, who's our nurse practitioner in the office, along with whoever operated on the patient for their post-op care. Sometimes it happens together, sometimes it's separate. So the relationship starts early in the hospital and then extends on beyond that.
That's interesting to hear, because I think that's the part that I've heard others have struggled with, is that inpatient kind of capture, because like you said, you have a captive audience, especially hip fractures. That's an obvious place to target. You can even think about vertebral compression fractures, but having that engagement early on, rather than just kind of set up outpatient referral, which I think is a lot of times the default that we do. How critical has that been to making sure that you get follow through? Because I can imagine that just gets the patients already thinking about it, rather than 3 months later, then they have to come back for their bone health appointment.
Yeah, I completely agree. And it's been very successful for us that the early intervention with both the patient and the family has been key to our success with the inpatient crowd. Where we've struggled, ironically, is the outpatient. We find it more difficult trying to get our hand surgeons to refer a low energy distal radius fracture in a 51-year-old who had a low energy fall, or our spine colleagues who see compression fractures in a 65-year-old patient who just sat on the toilet a little bit more firm than she or he normally would. Those are the patients that are hard to get because they don't come to the hospital or be seen in the ER by our residents. And so we've had to really adapt and capture them in a very different manner. And you would think educating your hand surgeons or your spine surgeons would work, but it really hasn't, at least not for us. And I know you're a hand surgeon, so I'm not trying to pick on you. But what we've realized is if we talk to the front desk people who see these patients as they come in for their visit, they were the key to trigger referrals for us. And because we're all in one system, we got them to trigger referral. If they saw a compression fracture or a low energy distal radius fracture in a patient over 50, that automatically triggered a referral to our bone health program. And that had been a difficult problem that has really turned into be a success for us.
Yeah, that's fantastic. I hate to ask this question, but I think it's important to discuss. It's 2022 and finances can be tight. Is your bone health program a loss leader? And it clearly it's the right thing to do, but I think it's important to just put the cards on the table. Is it financially a viable model, or is it just something that's important to do and your department prioritizes it?
Yeah, well, you definitely got to get people to want to prioritize it in your department. But once you get it up and running, it's successful and it's better than break even. We make money on our bone health. We have a busy outpatient practice where we see a majority of the success in billing. We also can bill inpatient for a lot of the consults, even at the same time they come in with their hip fracture. We bill for their disease, their underlying disease, and counseling with our nurse practitioner. She just has to do it on a separate day that we're doing surgery, and she can't do it on the immediate pre-op day or the next post-op day, but that's usually not a problem. Our patients typically are in the hospital anywhere from 4 to 6 days. So we have a lot of opportunities. And I think if you maximize those opportunities, you can really make a successful program. And that's why we've been able to hire more people. But it's sometimes hard to get over that hump. When you first start and you don't see the revenue coming in and you hire a nurse practitioner or another APP, and the program is slow and ramping up, and it may take 6 months or 8 months or a year, depending on where you're at and what sort of referral system you have. That, I think, is the challenge. And then you got to convince the administration to hang in there with you, because in addition to making money, you're also taking care of a great group of patients. And it's really about, as you mentioned, doing the right thing for the community. But once you get past that, I think it can be profitable for everybody.
Thank you.
Kind of as a follow-up, I'd be interested to hear, now that program's been going on for more than a decade, for a group that's kind of interested, what sort of resources can the AOA provide? Is there like a framework for just kind of, when you pitch this to your sort of higher ups in terms of what your timeline should look like, kind of tips to maximize that billing, and then sort of a timeline in terms of what you can expect before you really should sort of say, okay, this is where your break-even point's going to be? Because I think, like you said, that's the struggle, is we know it's going to be a hard climb, and then convincing people of the importance of it. But once you kind of show, and you're obviously at a program that's had long sustaining success with it, how can we learn from that success when we're trying to implement that in a new market?
Sure. I think that's maybe one of the biggest benefits of Own the Bone, because they have a toolbox that provides you a lot of information on this. But we also recognize, and being part of Own the Bone, is that not every system, not every city, not every academic center is the same, and everybody's going to go about it differently. And so the lessons that we've learned and things that made us a success can be helpful, but maybe not always. And so at Own the Bone, what's nice is you can actually talk to a real person. If you are trying to set up your program, you're not getting a voice recording telling you, this is the number you need to call, please listen, so-and-so. You actually get someone who's going to talk to you and tell you about how to use the tools that we have. And usually we refer them out to different centers that have established a program. And usually we find a program that's very similar to what they are. So if they're a small community program that's starting out on the outpatient side, not the inpatient side, we usually have a big network where we can find another program that's done the similar type of setup, where they're relying on their outpatient volume. So very different than what I have at a level 1 trauma center with residents. And certainly my nurse practitioner sees probably 2 or 3 site visits a year from the referrals through Own the Bone, and they actually come out and look at what we do and how we do it. So that's very helpful. But I think what's exciting is, because we have such a big network and there's so many different pathways that you can choose to make it successful, we find the right path for each and everybody who gets involved in the program, which is, I think, exciting.
Very exciting and very well designed, and no doubt about that. Talk to us a little bit more about what Laura's practice looks like, and the team, I guess. Is she ordering and interpreting DEXA scans? Is she ordering medication? And the third question is, sometimes the medications are difficult to find insurance coverage for, and how does she handle those situations?
Sure. So early on, when we first started the program, as I mentioned, back in the early mid 2000s, we did some of our own prescribing. But again, at that time, the model was pretty simple. There were bisphosphonates, there's, calcitonin, and that was really about it, along with calcium and vitamin D. I mean, now it's kind of expanded, and there are a lot of different drugs on the market, and you do have to pay a lot of attention, and there's a fair amount of learning. If you're interested and you're involved, if you're an orthopedic surgeon, you may want to do that. But to your point, I think most orthopedic surgeons aren't going to be the ones treating. It's going to be their APPs or the referral network that they have, whether it's a primary care, a family practice doctor, a rheumatologist, etc. And so with Laura, she has really become very versed in all the medications, and she does all the treatment plans that we have. We start every patient that comes in with a fragility fracture in the hospital, when they hit the door and they get a consult, on vitamin D and calcium. And we usually order a baseline set of labs. And that's changed a little bit over the years. Some of these weren't paid for early on. Now we can get them paid for. So a lot of the labs will order ahead of time. Our residents are fairly versed in it. They meet with Laura every time we have a change in a shift on the trauma service, which is every 3 months. So she goes over, meets them, talks to them about what drugs, medications, labs we need to have ordered. And then occasionally we'll start the drugs when they're in the hospital, but most of the time we wait till they're over their fracture, and then she'll put them on the appropriate medication at that time. And as you mentioned, it can be really challenging. So a lot of times we're looking at these fragility fractures that may be difficult to heal. And some of these patients have already been on a bisphosphonate, which is a catabolic agent, not necessarily building bone, keeping you from losing bone. So we've moved to trying to get them on an anabolic agent, usually a teriparatide derivative, so PTH, and a couple drugs on the market that have that. They're expensive, and there's actually generic, which is still expensive, so 3 total. And they're injectable, and they require a little bit of education, and that's what Laura does well. But what she's also done really well is found pharmacies across the country that are willing to work with her and work with the patients and their insurances. And it's pretty amazing. With a little bit of effort, she has done an amazing job of getting most of our patients the drug for 18 to 24 months, which is typically the time frame for the anabolic agents. And it did require a little bit of time and patience. And I would say probably the majority of the calls she gets through Own the Bone from other sites is how she did that, who she works with, and what are the successes. And then the other point I would add is also some of the companies now are really good. They have their own support groups and support networks that will help you get the drug. So it is a challenge, though. There's no question. When you tell a patient they're going to be on a drug that's going to cost $2,500 to $3,500 a month, they're looking at you like they're crazy.
It sounds like you've got a total winner with Laura, and you got to never let her go, because
you're right.
That's
day.
Unbelievable. Like the effort and the engagement, and just being able to kind of continue that, and the kind of creativity of being able to find that. I mean, that's obviously, and you kind of mentioned at the beginning, that's key, is getting that site champion and sort of getting someone that's really bought into it. I guess one of the things that we talk about is kind of just, should we screen vitamin D levels in all of our patients, fragility fracture, not fragility fracture? We've kind of had our total joint surgeon starting to do that. You mentioned sort of the benefits that we've seen with Own the Bone, kind of expanding beyond fragility fractures. Be interested to hear your thoughts about just like what sort of, and when should we kind of start screening in our elective patients? And is that maybe another avenue to potentially get more buy-in into these Own the Bone type initiatives, because now it's applying to all of orthopedics? As you mentioned, it probably does apply pretty broadly, but kind of taking that next step.
Yeah, for sure. And I would tell you that with Own the Bone, that has been one of our biggest focuses over the last 2 to 3 years, is really trying to expand into the elective market where we think we can make a difference. As I mentioned briefly about spine surgery, total joint surgery, but even sports medicine in some respects. We see young people that have problems with their bone health, especially amenorrheic, thin people, these athletes that are doing a lot of running. There are opportunities for intervention and understanding bone health and making a difference. And shoulder surgery, you mentioned early on, what could that matter? Well, how many times have you put in anchors that pull out, right? And these patients that are 55 now that have a rotator cuff, but they're playing tennis 4 times a week. They're healthy and they want to get back to doing all this sort of stuff. And that's not a good feeling when that happens. And so I think those are opportunities where we can make a difference in our elective patients before they have a fragility fracture.
That's fantastic. Maybe as we start to wind down, early on, you mentioned the education process, and I guess that could pertain to patient education, trainee education. There's a lot of different directions, but just explain how, and you've touched on it a bit, but just maybe to recap how the Own the Bone program helps with education of the different groups that need it and that will benefit from it.
Sure. So there's an abundance of opportunities. I would tell anybody who's even interested a little bit in bone health and Own the Bone to go to the site. And a lot of it you can see even without being a member, just to understand what it has to offer. But I would tell you almost all of the education that Laura Bueno, who, as you mentioned, is fantastic for us, picked up is through a lot of the educational activities that we have. So we have a webinar every quarter. There are webinars since I think 2018. They're recorded and they're on site, so you can pick and choose what it is you want. If you want to learn how to start an Own the Bone program, you can listen to a 40-minute webinar on it. If you want to hear about calcium and vitamin D, the risks and benefits, you can go on there. You can look at the drugs that we talked about a little bit today and see the site, see there. There's some programs on there. One of the webinars I think I did was how to start an Own the Bone program. So the webinars are really key. And then we have also a program called Bone Health Echo, which is once a month. It's usually on Thursdays at noon. It's an hour and it's free, and you can join there and just listen to other people present difficult orthopedic patients that have bone health problems and how they're managed. And there are also topics that fluctuate from month to month that pertain to these topics. So those are just a sort of a snapshot of some of the educational activities. And we have an annual symposium once a year. That's an all-day event, which we've now converted to breaking it up into 3 sections with Zoom. And so you can get on and actually hear a lot of the stuff that we're talking about today in more detail through some of these experts. And just to brag on Laura a little bit, she got to run the symposium for a couple of years along with a physician who is interested in bone health. And so she's really been active in the education side through the AOA and Own the Bone.
Well, that's a great way to wrap things up, Dr. Jeray. Huge thanks for joining us. And I think for those interested, checking out the Own the Bone website on the AOA, great resources. Sounds like tons of information and can really build on the experience that's you and your team. And big shout out to Laura. Sounds like she's really the heart that keeps that thing going. So appreciate your time, and thanks again for joining us.
Thank you.